Hello students, this is Anne Graf-Ladisa, and this lecture will cover topical medications. These are my objectives for you. I'd like you to be able to identify commonly used topical medications to treat ailments of the eye, ear, skin, mouth, and throat, explain the benefits and risks of topical anesthetic use, and also be able to teach patients the proper administration of topical medication. When we talk about topical medications, these include a wide variety of medications that can be applied to the skin or mucous membranes for a treatment effect. Now with topical medications, we're really looking for a local effect at the site of application versus a systemic effect. And the good thing about this is that we have fewer drug-drug or drug-disease interactions to worry about because we're just getting a local effect and not a systemic effect. However, it's important to note that in your young patients and your old patients, you have to be careful because they may be more susceptible to systemic effects of these topical medications because of their skin or because of their skin to body weight ratio, as we talked about in week 1. So topical medication preparations can include creams, lotions, ointments, solutions such as drops that you might put in your eye or your ear, sprays or powders, so all sorts of different things. Many of these medications are available over the counter. Some are available over the counter but also have a prescription strength that can be written for by a provider. So the thing with topical medications also is that proper administration is imperative to effectiveness. So the effectiveness is only going to be as good as the person who is applying the medication. So if they're doing it correctly, you should get an intended effect. However, if the application or administration technique is done incorrectly, you're probably not going to get as good of effectiveness out of the medication. So we'll start with ophthalmic medications or medications for the eye, and we'll talk about anti-infective ophthalmic medications, ophthalmic medications for symptomatic relief, such as anti-inflammatory products, anti-allergic products, and also vasodilators or antihistamines for redness or itching. And we'll talk briefly about anti-glaucoma medications, although you may see patients in the primary care setting on anti-glaucoma medications, you likely won't be prescribing them as they'll be prescribed by a specialist, by an ophthalmologist. With anti-infectives for the eye, we're typically treating an external ocular bacterial infection, typically something like a bacterial conjunctivitis in the primary care setting. There are antivirals, eye antiviral medications that are available, but likely those will be prescribed by an ophthalmologist as well. So as with any anti-infective, what medication we use is going to be dependent on what organism is likely the cause. So some common classes of antibiotics that we see used for treatment of bacterial infections of the eye are quinolones, aminoglycosides, and sulfonamides. So to refresh your memory from earlier in the course, quinolones work by inhibiting DNA gyrase in susceptible organisms, and this inhibits relaxation of supercoiled DNA and promotes breakage of double-stranded DNA. Quinolones are bactericidal, and some that we see that come and that are available in ophthalmic preparations are ofloxacin and ciprofloxacin. Aminoglycosides are also a common agent of antibiotic used in the eye. Aminoglycosides bind to the 30S and 50S subunits of the ribosome and inhibit bacterial protein synthesis in susceptible organisms. And what this does is it results in a faulty cell membrane of the organism. Medications that we see used in ophthalmic preparations of aminoglycosides include gentamicin and tobramycin. Sulfonamides are also used in ophthalmic preparations of antibiotics They work by inhibiting bacterial folic acid synthesis via competitive antagonism of PABA. They are also bacteriostatic. So sometimes we need an anti-inflammatory agent to treat local eye inflammation due to infection or due to severe allergies, or sometimes post-eye surgery anti-inflammatory medication will be prescribed for the eye to be used topically. So we can use NSAIDs or nonsteroidal anti-inflammatories as ophthalmic preparations for this indication. Some that are available are diclofenac or ketorolac. And NSAIDs work the same way oral NSAIDs work. They inhibit cyclooxygenase, which inhibits the synthesis of prostaglandins. Corticosteroids can also be used as an ophthalmic anti-inflammatory medication. And a lot of times we'll see these anti-inflammatories used in combination with an anti-infective. So we're treating the cause of the inflammation by treating the organism that's causing the infection, and then also the symptomatic control of the inflammation and redness. There also are specific anti-allergic ophthalmic preparations. These are used to treat the itching that is associated typically with allergic conjunctivitis. So you can get an antihistamine only product, but some of these products are mast cell stabilizers, which inhibit the degranulation of sensitized mast cells that occur after exposure to the specific allergens, but then they also inhibit the release of antihistamine. So we can also treat redness of the eye with a local topical ophthalmic preparation of a vasodilator. So these are your over-the-counter products such as Visine or Clear Eyes, and essentially what they do is constrict conjunctival eye vessels. It's important to advise patients to limit their use to less than 3 to 4 days if they're being used consecutively, because what can happen is if used for longer than 4 days in a row, you can have a rebound ocular congestion, which can be very uncomfortable for patients. So we're going to briefly talk about anti-glaucoma medications. The specific mechanisms of action for these medications are outlined in the text, but basically anti-glaucoma meds lower intraocular pressure by either reducing how much fluid is produced in the eye, and this is called the aqueous humor. So reducing how much fluid is produced in the eye, or decreasing eye muscle resistance to that fluid, or by helping to encourage outflow of the fluid, or sometimes a combination of all these things. So by reducing the intraocular pressure in the eyes, it helps slow optic nerve damage and decreases the rate of vision loss that's associated with glaucoma. So there's a lot of different classes of agents: ocular beta blockers, alpha-2 selective agonists, miotics, diuretics, and also prostaglandins. So as primary care providers, you should be able to recognize an anti-glaucoma medication that a patient is taking, but really these are going to be prescribed by ophthalmologists based on the type of glaucoma that the patient has and other comorbidities. So as primary care providers, your role is just to monitor for adverse effects. There is some systemic absorption that may occur when using the classes such as the beta blockers. So you can monitor blood pressure and heart rate. However, in most patients, they will have the systemic absorption will be so small that they will mostly have non-detectable levels of drugs in their systemic circulation. Another thing that primary care providers can do is reinforce administration technique of their glaucoma medications to make sure that they're getting the full effectiveness of the medication. So we're going to just briefly review how to insert a drop of an ophthalmic medication. So first you want to make sure that you instruct the patient to wash their hands and avoid touching the top or the tip of the dropper to anything, especially their eye, and this is especially important if they're treating an infection of their outer eye. So while tilting their head back, they should pull down the lower lid of their eye with their index finger to form a pocket, and that's illustrated in the picture on this slide. So they should look up and gently squeeze the dropper so that a single drop falls into the pocket, and then they can remove their index finger from their lower lid. Then they should close their eye for 2 to 3 minutes and tip their head down as though they're looking to the floor, trying not to blink or squeeze their eyelid, and placing a finger on the tear duct and applying gentle pressure. So it's also important to tell patients that when they're prescribed more than 1 drop of medication for their eye, to wait at least 5 minutes before instilling the next drop to make sure that the first drop has a chance to absorb. I think ophthalmic ointments are a little bit trickier for patients, and a lot of times they're not exactly sure how they're supposed to be putting this medication into their eye. So if you're prescribing an ophthalmic ointment, make sure that you cover this with them at their visit. So they should again wash their hands and then avoid touching the tip of the tube to anything, especially their eye if they're treating an infection. So again, tilting their head back, pulling down that lower lid to make sure they have a nice pocket formed. And then they should squeeze a ribbon of the ointment into the pocket made by the lower lid and then releasing the pocket with their finger. So then they should blink gently and close their eye for a minute or 2. And then they can just wipe any excess ointment from their eyelashes or around the outer eye with a tissue. And then with a clean tissue, not the one that they use to wipe their eye, wipe the tip of the tube clean so that the ointment doesn't get everywhere. So otic medications are used to treat ailments of the ear, and we typically see these used to treat external ear infections and pain such as otitis externa or swimmer's ear. Otic medications usually come as combination products, which will include an antibiotic or an antifungal plus a corticosteroid for an anti-inflammatory, and then it may or may not include a topical anesthetic that provides pain relief until the antibiotic or antifungal starts working. Quinolones that are aminoglycosides are classes of antibiotics that we'll see often in otic preparations. Hydrocortisone is a common corticosteroid that is used, and then benzocaine or pramoxine are common topical anesthetics that provide the analgesic effects. It's important to note that ophthalmic medications or medications for the eye may be used in the ear. However, a medication that is specifically prepared for the ear or an otic medication may not be used in the eye. So when eardrops are accidentally instilled in a patient's eye, it's usually pretty obvious. Patients quickly let you know that something is very wrong. Typically they'll complain of burning or stinging, and they may notice redness or swelling or blurred vision. So it's important to make sure that you don't confuse the otic and the ophthalmic preparations. So we'll just review briefly how to instill an otic medication into the ear. So first you'll have the patient wash their hands and then hold the medication just for a few minutes to warm it up. It's a lot more comfortable if the medication going into the ear is warm. Then the patient can lie on their side with their affected ear up. This is best, but it's not always possible for the patient to lie completely on their side. And you can see in the picture on the left of someone just tilting their head so their affected ear is facing up as best as possible. So they should pull their ear backward or have someone pull their ear backward and upward in order to open the ear canal, and then instill the drops. And if there's more than one drop, they can instill them one right after the other. Gently press on the ear flap over the ear, and then keep the affected ear up for 2 to 5 minutes. Or if that's not possible, they can plug the ear with a cotton ball to prevent the medication from draining out. Now we're going to talk about topical skin medications. And before we go into the different kinds of skin medications, we need to talk a little bit about the vehicle or the inactive ingredient that the drug is mixed with for purposes of applying the medication. So the vehicle can be a cream or an ointment or a lotion, powder, gel, or foam. And the choice of what vehicle you should use should be based on where the patient is applying it and the convenience of applying it and leaving it on. Okay, so if you have an ointment, ointments have very little water in them, so they're kind of greasy. Cream has more water in them, so they're a little bit more topically pleasing and feel better. Lotions have the most amount of water, and so they kind of readily absorb and probably feel most comfortable for the patient. However, the amount of water in these vehicles has an effect on how much drug you can actually put in the vehicle. So ointments, although they are greasy and not pleasing for patients, they really penetrate the skin best because they form a very nice occlusive layer on the skin, which encourages absorption, and you can concentrate the drug more into ointments. However, a patient might not want to wear an ointment that's exposed to air, for the course of 12 hours, just because it can rub on clothing and things and kind of get greasy. Creams are usually the most desirable for patients. They rub in very nicely, however they can wash off easily. Lotions are by far the easiest to apply, especially on areas that have a lot of hair, but they are also less able to concentrate drug into the lotion. A thing to note with foams and gels is that they may contain alcohol, which can be drying to the skin. So that's important for patient comfort, as well as for patients that have any type of dry skin conditions. So a couple other things about the absorption of topical skin medications. It's obviously absorbed through the skin at the application site, so a local effect. However, it's usually slow and erratic. So you're not getting the systemic absorption, which can be good, but the absorption could be more inconsistent. If the patient has broken or injured skin that they're applying the medication to, this can increase the risk for systemic absorption because of the injury or the broken skin. Also, if an occlusive barrier is applied over the application site of the medication, it can also increase the risk of absorption. So if a patient puts on a cream or an ointment or something and then puts on like plastic wrap or puts a heating pad over it or something like that, that can increase the risk, increase absorption and potentially increase the risk for systemic effects as well. So of the topical antibiotics that we have available, most have very good gram-positive coverage, which makes sense because our normal skin flora contains gram-positive organisms. And so when we have a minor cut or an abrasion or a burn, it's likely these gram-positive organisms that are causing the infection. So a lot of the Topical antibiotics are available over the counter, such as Neosporin, which is a triple antibiotic that contains neomycin, bacitracin, or polymyxin. And patients will use these as infection prophylaxis, but you should advise them that if they don't see improvement in 3 to 5 days, or if you see a patient who comes to visit you after 3 to 5 days of using these, and the infection has not improved or perhaps gotten worse, they might need a systemic antibiotic at this point. We also use antibiotics in the treatment of acne. We'll see clindamycin or erythromycin used as a topical skin medication for acne. Also, mupirocin is one that's commonly seen as it comes as a cream or an ointment, and it's used for the treatment of impetigo. And we also see it used in the hospital to eradicate, it's used intranasally to eradicate nasal colonization with MRSA. We also have a variety of topical antifungals that are available, and these are usually used to treat tinea and other susceptible Candida species. So nystatin's a pretty common one. We see that as a cream or an ointment or a powder that we could use on the skin. Clotrimazole, miconazole, tolnaftate, terbinafine, and others. A lot of these are available over the counter, and we have this Candida species or fungus that kind of is our normal skin flora, and when we have overgrowth of this on our skin or our nails or our hair, it can cause infection. These antifungals typically work by altering fungal cell permeability. So the cell membrane of the fungal cell is unable to function as a barrier, and then potassium and other cellular constituents is lost. These medications are basically fungus static, however some are fungicidal when used at higher concentrations. Topical corticosteroids are used for a lot of different dermatologic indications, anything from poison ivy to psoriasis, eczema, or the various types of dermatitis. And they're used really for their non-specific anti-inflammatory effects. The good thing about topical corticosteroids is that they suppress chemical, mechanical, microbiological, and immunological mechanisms of inflammation. So they're very non-specific. They can decrease edema, erythema, and pruritus. The different corticosteroids are classified by potency. So you'll have low potency, medium, and high potency. These are typically applied either once or twice a day. And although it really is, a local effect, if high potency formulations are used continuously for greater than 3 weeks, you can get some systemic effects. And if patients are using them long term, these high potency formulations, they may actually need to be tapered off of them. So using long term high potency formulations is usually best monitored by a specialist like a dermatologist. A couple of special populations to consider when prescribing topical corticosteroids in your elderly patients. They may have thinner skin, which can lead to increased systemic absorption, and the corticosteroids may have a more drying effect on their skin. So it's important to advise them of that. With pediatric patients, we usually want to use lower potency steroids for shorter periods of time. This is because they have that larger skin to body weight ratio that we talked about in week 1. So compared to adults, there's still a lot of surface area to absorb the medication based on the application, but because they weigh less, there is that possibility for a larger than desired dose to be absorbed. So now on to some of the fun stuff, scabicides and pediculicides, the treatment of mites and lice. So these are some common agents that you might prescribe as a primary care provider. I'll talk about 2 of them. First, permethrin is a very common one. And this actually inhibits sodium ion influx through nerve cell membrane channels in the lice that results in a delayed repolarization and paralysis and death. So essentially you're paralyzing the lice and causing them to die. This medication is commonly prescribed because it's safe to use in children greater than 2 months old. And it's important that patients or the parents of the patients use the medication correctly in order to eradicate the lice. So you apply it after shampooing, and you have to make sure that the cream rinse sits after applying it for 10 minutes and then rinse it. And make sure that they comb their hair with a fine-toothed comb afterwards in order to remove any remaining eggs. So Lindane is another medication that is used, but it's not first line due to some of the adverse effects. There has been reports of serious neurotoxicity and seizures with repeated use, but you can assure patients that this rarely occurs with a single application. It's directly absorbed by the parasites in the ova through the exoskeleton, and it stimulates the organism's nervous system, kind of overstimulating it, which results in seizures and deaths of the scabies or the lice. This should be avoided in children and also in patients that are less than 50 kilos. It certainly should be avoided in women that are pregnant. Also avoided in elderly patients, and then people who have inflammatory skin conditions where they might have a breakdown of the skin, which can cause the medication to be absorbed through the skin more rapidly. So we want to make sure that the patient is using gloves to apply and wash their hands well. And they are to apply the medication to dry hair and then adding just enough water for lather, and then they need to let it sit for 4 minutes after application and then rinse it. And they should also comb their hair afterwards in order to remove any remaining eggs. So some medications that are used topically in the mouth or in the throat can be medications to treat oral candidiasis or thrush. Clotrimazole comes as a troche or a lozenge that patients can suck on. Also, nystatin comes as an oral solution, and although patients are instructed to swish and swallow this, it's not a systemic effect that we're looking for. It really is a local topical effect in the mouth and the throat, so that you want to make sure that they're instructed to swish it well and to swallow it so that it coats the throat. Also, there are some medications that are available to treat cold sores, and these need to be used at symptom onset, so when the patient first starts experiencing kind of that the signs that they're going to get a cold sore, and making sure that they understand this really just manages symptoms. It doesn't eradicate the disease. So once you have cold sores, you will always have cold sores. It's a herpes virus. So these are topical antivirals that are used. They inhibit HSV or herpes simplex virus polymerase, which in turn inhibits herpes viral synthesis and replication. So some of these medications are the penciclovir cream and also the acyclovir cream. I also want to talk about topical anesthetic use. So some topical anesthetics that are used are lidocaine, tetracaine, benzocaine, prilocaine, and others. They come in various formulations: creams, ointments, gels, sprays, and patches. They work by reversibly blocking nerve conduction at the site of administration, which causes a temporary loss of sensation or numbing. And a lot of times these are used to relieve pain, burning, itching, or numbing the skin for procedures. And they're available over the counter or by prescription. So these are very useful agents. However, it's important to know that there are risks with topical anesthetics. So there have been reports that they are used prior to cosmetic procedures. So perhaps before laser hair removal or before tattooing. And what the risk is that large amounts or more than acceptable amounts may be applied to the patient's skin if not done by a trained professional. Also, patients may be instructed to put an occlusive layer over these topical anesthetics, and in some cases this can be a benefit because it will absorb quicker and more rapidly and more extensively. However, when this is done, then you get that extensive absorption, which can cause systemic absorption. And some of these medications can be very toxic. They can cause arrhythmias, seizures, and death. The FDA did put out a warning several years ago, and I put a link to it on the overview page for this unit that you can read. But it is a real concern, and patients should be instructed to make sure that there is some sort of oversight by a medically trained professional and that they're following instructions to the letter. Other side effects with topical anesthetics are a risk of methylglobinemia, and so we really saw this a lot in hospitals when they were using hurricane or benzocaine spray for bronchoscopies. And so really it's important when using these that we monitor for oxygen saturation because of the risk of methylglobinemia. And this concludes our topical medications lecture. Please post any questions on the Ask the Pharmacist discussion board for this module. Thank you.